Here is the question, not too much. Right. So if you have read and understood, kindly tell me what would be your differential diagnosis?
And my differential diagnosis would be, according to the scenario, it may be a case of undescended testis. It may be a case of inguinal lymphadenopathy. It may be also a case of lipoma of the spermatic cord.
Yes.
And it may be a case of infected pseudoaneurysm. It may be a case of also a testicular cancer.
Okay, good.
Or
How would you confirm your diagnosis?
Yes, ma'am. I would take adequate history from this patient, and I would like to do the relevant clinical examination. And after that, according to my differentials, I would like to go for first blood test to see any evidence of infection over there. Then I'd like to full blood count, ESR, CRP level, and after that I'd also like to check the routine other investigation like liver function test, urinary electrolyte, urine dipstick to see any evidence of urinary tract infection over there. And after that I'd look to go for any imaging modalities for this patient. We can do an ultrasonogram for this patient.
What would you see on ultrasonogram?
Yes, ma'am. For a case of, according to my differentials, a case of, we can see the scrotal, you can see the testicular, we can see the testicular testicular mass or inguinal lymph node like growth, solid or cystic solid
component,
or heterogeneous mass. Yes, ma'am. Yes, ma'am. Heterogeneous mass.
This will help you.
And after that, we can also do a CT scan, and we can, last of all, we can do also a FNAC from the or tissue sampling from this mass.
What do you expect to see on histology report?
Yes, ma'am. In case of histopathology report, like according to the diagnosis, like if it is a lymph node, we can see three patterns like follicular hyperplasia, or maybe paracortical hyperplasia, or maybe sinus histiocytosis if it is a inguinal lymph node. And in case of testicular mass or undescended testis, we can go see a typical pattern of the testicular tissue if we go for histopathology and immunohistochemistry. And in case of histopathology of testicular mass like testicular cancer, we can do the histopathology and immunohistochemistry. We can see the malignant changes of the gland on histopathology, and on immunohistochemistry we can also see some certain markers over there that they may be positive.
Can you tell me what is the most common location of undescended testis?
It most commonly located at the deep ring, ma'am. Inguinal canal, like in 70% cases.
Okay. How would you differentiate it from ectopic testis? Give me 3 to 4 differentiating points.
Yes, undescended testis is obstructed in its normal pathway of descent towards the normal scrotal sac, and the ectopic testis is deviated from its normal pathway of descent.
Good.
And in case of spermatic cord, the length of the spermatic cord is shorter in case of undescended testis, and it may be longer in case of ectopic testis. And in case of undescended testis, the spermatogenesis is not normal, maybe less adequate. In case of ectopic testis, it is fully normal. The development of the scrotal sac is fully okay in case of ectopic testis, and it is underdeveloped in case of undescended testis. And undescended testis is associated with the increased risk of inguinal hernia, and ectopic testis is not associated with that. And the treatment option may be for undescended testis like hormonal treatment or surgical, but in case of ectopic testis, it's fully surgical.
Very good. Okay, can you tell me what are the etiology for testicular carcinoma?
Yes, ma'am. It may be a congenital like undescended testis, cryptorchidism increases the risk.
Yes.
It may be, ma'am, familial deposition, like in case of father, if the father have undescended testis, it increases the chance to 2 to 4%. In case of brother, it increases the chance to 8 to 10%. And it may be, ma'am, a genetic predisposition also, like positive family history. It may be some kind of and some kind of
Environment.
HIV associated, some kind of HIV infection associated with drugs, and also like previous history of any associated cancer. It can also increase by
Can
that.
you define cryptorchidism?
Cryptorchidism is, ma'am, the absence of the testis in one of the scrotal,
Complete
one
or
or
partial?
both of the scrotal sac, ma'am.
Yes.
Actually, the location is not known in case of cryptorchidism.
Okay, what might be the cause behind it?
Ma'am, it may be a congenital cause. Most likely, it occurs like the congenital undescended testis. There is a lack of descent of the intra-abdominal testis. It may be due to increased intra-abdominal pressure, or incomplete descent due to faulty of development of the caverniculum testis also.
Yeah, like low birth weight, premature birth.
Yeah,
etc.
low birth
Alright.
weight, premature birth. Yes.
Down syndrome, etc. Okay, what might be the complications?
Yes, ma'am. It is associated with increased risk of testicular carcinoma, increased risk of testicular torsion, and increased risk of inguinal hernia, and it may also cause infertility in future.
Okay, considering this scenario, can you tell me if it would be a teratoma or a seminoma?
According to the scenario, it may be a case of seminoma.
Why?
Most of the case, the seminoma affects more than equal to 30 years of age.
Yes,
More age
and?
is increased age is affected by seminoma. That's why I think it may be a case of most common.
If you do serological markers, what would you find?
In case of serological marker, we can look for the placental alkaline phosphatase, and
yes.
also we can look for beta ICG level, and
Yes.
also we can do a check for the LDH level, like the cell turnover, the cell breakdown, and new cell formation. That may be also increased in case of seminoma more than other carcinoma.
What might be the cell of origin for seminoma?
Ma'am, it may arise from the intertubular germ cell neoplasia, like from the atrophic tubules.
Okay, all right. Yeah. What is the origin in case of teratoma?
Ma'am, teratoma is a kind of tumor that arises from that grows into some derivatives which are derived from the more than one germ layers. That is called teratoma.
All three germ cells. Okay.
All three. Yeah.
Can you tell me, if you'll
yes.
do the histopathology, what should seminoma look like?
If we do go for histopathology, ma'am, there may be a classical pattern or a septed pattern we can see. Actually, not much I can do.
Okay, can you tell me how would you stage and grade the seminoma of the?
Yes, ma'am.
Or the
yes,
testicular
according like for the testicular tumor, actually we can do it according to the TNM staging, and also included in case of testicular carcinoma, that is serum marker, and it is called actually TNMS. So T depends on the tissue size, like if it is 1 to 2 centimeter is T1, 2 to 4 centimeter is T2, and 4 to 6 centimeter is T3, and like more than 6 or 7 centimeter is T4. And N means, ma'am, at first the nodal metastasis, like if it is at first it goes to the parotid lymph node, it is N1, and unilateral actually, and it is bilateral parotid lymph node, so it is actually N2. And in case of M, it indicates the distance metastasis is present or not. That is M0 or M1. M1 means metastasis present, okay. M0 is not present.
Can you please tell me the WHO's classification of testicular tumor?
Yes, ma'am. Like the testicular tumor and swelling can be different types. At first, we can do the testicular malignancy, that is divided into seminomatous and non-seminomatous germ cell tumor. And the non-germ cell tumor, that includes the seminoma, and non-seminomatous includes teratoma, brain cell carcinoma, yolk sac tumor, and choriocarcinoma. And it can arise from the sex cord estomal tumor, like Sartori cell or Leydig cell tumor. And it can also arise from the blood cells of the hematopoietic system, like leukemia, lymphoma. And it can also arises from the paratesticular tissue, like paratesticular tumor like neoplasm, or this is the classification.
Okay, one last question. Bell is gone. Beta HCG level, you said, can be raised in case of seminoma. This serological marker can be raised in any other conditions as well. Can you name few, please?
Yes, ma'am. Actually, it can raise, it is also called the pregnancy hormone. It's actually detected after 8 to 9 days after ovulation of a menstrually active woman. And it can be detected on urine and blood sample. And also without pregnancy, it can also be detected after the 8 to 9 days of ovulation, like elevated in case of a female menstruating woman. And also like some placental tumor, from there, it can also be raised, ma'am, other than this seminoma.
Okay, good. It also can show recurrence, you know, of carcinoma.
Yes, in case of seminoma, it can detect the recurrence.
Yes. All right.
Like the content, if it is the content is sensitized to topoplastic, in 30 to 40% cases, it can show the recurrence.
Yes, good. All right, very good, excellent. Yes, choriocarcinoma, yes, I didn't talk about it. No FNSE.
Yeah. If it is suspected testicular mass, so no FNSE. I actually told the FNSE
remove
for the lymph node.
The whole, yes. You just remove, yeah. Very good. Yes. Okay. Any other feedback? Yes.